Okay, so this was actually his talk, which he delivered yesterday, and we are trying to get his talk down back. And Sohail, please come for the. We are going back to China, Beijing, for what they are doing with that retrograde case. Over to Dr. Sohail to carry.
Okay, hello, the panelists and the moderator. So,
it's not the end result in a CTO, it's the journey which is very important. And it is with great regret that we had not to witness the great wiring skills.
OK， 永健，能听得见我们说话吗？
我现在听见了，我看你们有那边已经那个 lecture 已经结束了哈，现在又回来了。
永健。
Okay, so here is Beijing. So the welcome back to our CAS lab. So now is the anti-grade wiring is across the circulation, but now is the problem is very stiff. So and micro caster can't cross the circulation, and now we use the very small balloon, the 1.0 the balloons, and to dilate the circulation.
One can see that it's a Judke.
No, because there is a guiding. No. Because the guiding caster is
performance wire which is crossed.
Now, so we changed because this guiding caster is GI is the support. So now we change the guiding caster with the extension wire.
So why are they changing, Dr. Chen, why are they changing the guider?
Yeah, because this GI is not the private the strong support, and we try because this wire is the Gaia 3, so and we use the small balloon for the anchoring in the small branch, and we cross the Gaia 3 to the distal. Very careful.
You know, sometimes what I do is I put in a parallel Gaia 3, two of them. That gives the guide a lot of support also, and you can cross. So if they are having problem in crossing with the balloon, they can do a parallel buddy wiring with the second Gaia, and that gives a lot of support for the guider and facilitate in the process.
Yeah, so this now is blown.
He can't hear you.
No, it's
永健，就你们把右冠的直引导管从 GR4 换了一个新的，是吧？
对 ，GR4 现在是没有，现在这个 GR4 也不能提供足够的支撑。我们想的呢，可能会用一个这个球囊去铆定，先用这个去换那个 guiding， 因为那个单用那个阿巴斯那个 guiding 啊是有足够的支撑力，但是你想那个穿刺右冠近端的这个前缘帽是非常困难的。所以呢，使用了一个这个 G2 的这个没有支撑力的这么一个这个 guiding 啊，钢丝过去了，但是球囊过不去。我们现在想的呢，就是当然这个情况下可以采取了一个方案，就是我们把近端充分的扩张的足够了以后，加一个 GARZ 了。
Yeah, they did not change guiding caster at all, but you know they have successfully recanalized the lesion using wire, but balloon could not go through. So they have two options. One is using small balloon to anchoring micro caster. Secondly, they tried to open the protein RCA animal and then to use guide to support the wire. Two options.
Okay, so if you cannot anchor a buddy wire would be a very good option. And
I can't hear.
And that gives the
I can't hear you.
It doesn't buckle.
Right.
And it
I can't hear.
Ruptures, breaks the proximal cap also, and your balloon can then go.
Yeah.
Yeah. I mean,
So
it looks like they've crossed this with a Gaia third wire, haven't they, basically? And now they're struggling with a microballoon. So you've got a few options here. You can think about putting in a guide extension catheter to increase your backup support. That can sometimes help. If micro balloons are not going, then your other option is to think about putting a microcatheter down. So you can attempt a microcatheter. Sometimes a microcatheter might get across there, in which case you can put a supportive wire down or possibly even switch out to a rotor wire as well.
So
now we change it. So because
down, then a balloon would go down too, so that solves the problem.
Yeah.
But what I'm
No
suggesting
support,
is if
no
your
support.
balloon or micro doesn't go, then take another dietary.
把点弄好，不。
And that gives you tremendous support and it breaks the
你有
calcium and
拿一个新的
along the way. It works a lot of times for me.
Yeah. I mean, the difficulty there is that, of course, your second wire, you don't know where it's going to go. It might go
You've
subintimal.
got a very good map with the previous wire.
Yeah.
So just follow that wire and it just goes there.
I mean, there's no guarantee that it will go into the true lumen. I mean, I think if you're going to do a parallel wire technique, you probably need to still work on the first wire to make sure that you're in the true lumen, or think about a retrograde injection to make sure that your second wire is in the true
With the first
place.
wire in, you have a good roadmap what to follow.
Oh no, absolutely, I agree. So
Switching
I think
out-
they're just sort of going through the algorithm about failure to cross here, so that they're going to probably just think about
If you
what
can
they
have a
need to
good
do here.
anchor, good guider, a micro goes down, then the problem is solved.
Yeah, I mean, I would probably reach for a guide extension catheter in my practice in this sort of setup, because the problem that they're having is that the guide catheter is just backing out every time they're trying to advance the microballoon.
The problem here with the extension is that there's so little entry to the right. It's almost like an
哎呀，不要
osteo.
着急，不要着急，
If it was
不要
like
着急，
mid
改一下，
lesion, your extension go down.
不要着急，不要着急，不要着急，
But here the guider extension may not be useful. So
往死走。
Switching out for a wiggle wire, I find wiggle wire is very helpful in this as well. A wiggle wire is very helpful in this situation as well. A lot more support, and the bends can help you track things down. And also,
Oh, maybe now you can
if you're
pull back
fairly
because of
confident that your true
the right.
a short atherectomy with a small rotaburr just in the proximal segment might help you get stuff down also. Obviously, there's a risk that you're not true lumen, and sometimes you can
but you
hit that
have to
mutation.
get your rotor wire down first.
Yeah.
来看，你先看着，你先把嘎顶往上提一下，把嘎顶提一下。So
Dr. Chen, if you could tell them that the time's short and the other live transmission is ready. So we missed a great case. We'd love to know what happened
I
here.
will tell them.
We will, if you have time, we'll come back to them. But we're going to Singapore.
Okay.
If you'll excuse them for us.
永健，
OK，
哎，
Yeah.
永健现在是这样的，就转播的时间呢已经到了，下面还有一个讲座，我们就先去下一个讲座，完了以后如果
好的好的
有时间我们再回来，如果没时
OK，
间我
OK
们就不回来了。谢谢你们。
好了，谢谢。哦，你现在今天你能到那里去啊？我一直我不知道你应该能够出得去。
Thank you, Professor Wu. And if we get time, definitely we will try to get back to you to find what happened and how did you finish the case. And now we go live to 10 Tock Seng Hospital, Singapore, where our great friend and operator, Dr. Fahim Jafary, is waiting for us for his live case. Over to 10 Tock Seng Hospital, Singapore. Fahim, can you listen to us? Assalamu alaikum. Welcome to Pakistan Live 2022, and it's great to have you with us. And can you ask somebody to introduce your team and the case?
Okay, super. Good afternoon, everybody. Salam from Singapore. My name is Fahim Jafary. I'm an interventional cardiologist at Calcified Hospital at the Energy Heart Institute. And to my right, can you all see us?
Yes, we can. Fahim, nice to see you.
Yeah, we can hear you. Nice and clear.
To my right is my friend and colleague, Dr. Zhao, who is a senior consultant at Calcified Hospital and one is a consultant at an institution, recently returned from Colombia, where she spent a year with some of the world's experts in the field. We have at the back end, we have my other colleagues, Dr. Bharat, Dr. Ho, Dr. Cliff Lee, Dr. Randall, Dr. Tet, all of my colleagues who are helping with this. We have a great team here, a large team. You can see some of them. I'm not going to name everybody because there's a whole lot of them, but everybody is here, and I want to thank Boston Scientific for supporting us in this, and I want to thank Pakistan Live for inviting us for this fantastic conference. So without further ado, I'm going to ask Jason to introduce the case, if you guys can see the slides.
Before you introduce your case, let me introduce the panel of experts sitting with us.
Please do.
Sohail Aziz is along with me moderating this session, and we have got Sohail Khan from UK. We have got Rosli Mohammed, our great friend from Malaysia.
Rosli, yes.
We have got Dr. Osman Fahim. We have got Professor Mansoor Ahmed, and we have got everybody in the audience, including Professor Bashir Hanif and Samad Saab and Professor Nadeem Rizvi. And we had Shaolin Cheng also, and he'll be joining us in the panel this soon. So over to you to introduce your case.
All right, so can you see, let us know when you can see the PowerPoint slides. Great panel and great to have, we need a lot of help with this case. I think we can forward the video, these are the hospital video, and just move to the first slide.
Okay. All right. Good afternoon, ladies and gentlemen. It's our pleasure to bring you this live case today. Essentially, this is a 75-year-old Chinese gentleman. Significant risk factors: diabetes, hypertension, hyperlipid, and chronic kidney disease. Significant background history is giving heart disease, previous PCI done to the mid-circ, and the proximal RCA more than 20 years ago. And in 2017, had the DCB to the proximal RCA, stent ISR, as well as DCB to the distal RCA. So essentially, saw us for additional shortness of breath. And on review, the clinician decided to order a myocardial perfusion study. Essentially, what it shows is stress-induced cavity dilatation. And after clinic consultation with the patients and options being offered to him, the patient decided for the angiogram. So essentially, this is the angiogram that was done earlier this week. So basically, on the left side, there is significant moderate ostial to proximal left circumflex stenosis, as well as the mid to distal circ. There's actually a stent there with significant in-stent restenosis. So coming to the frame on the right, you can see the LAD and the left main. Essentially, in the distal left main, you can appreciate there is the moderate stenosis in sort of like a mid-left main, and a very tight mid-LAD stenosis as well. Let's go to the next slide.
Next slide, please. Yep.
That's the end.
Next slide. Can you see the next slide, guys?
Yes, we can see some good pictures.
Okay. Okay, so I'm not sure if you can see the next slide, but I want to, so maybe I can fill in with this bit because I was here in the lab. So he came in with the, left main disease, LA disease, circ disease, and while we were taking a picture of the right coronary artery, the Judkins catheter dipped into the ventricle, and then he went into essentially asystole and arrested on the table, and had about 10 minutes of CPR before he was, had return of circulation. So back to you, Jason.
So essentially this, let's go to the next slide. that is finished.
We're not seeing the sides advance, so. Okay. My apologies. Okay, so essentially, this gentleman has distal left main disease. He has severe mid-LED disease, severe mid-circumflex in-stent restenosis, moderate RCA disease. And at this point, we discussed the options with him of CABG versus PCI, and the patient was pretty clear he did not want surgery. He's 75 years old, felt that he was single, no immediate family, and he didn't want to go through the recovery process of surgery. And at this point, I think I will show you the images now. We'll just, let me show you, take you back to the images today, and then I'd like to know what your thoughts are and see what you will do. So can we show now the angiogram that we just took right now? Can you all see that, Dr. Zubair?
Yes,
we can see that.
Very good pictures.
Okay, sorry, we're having a bit of technical glitch on us, and it looks like you're able to see stuff and we're not able to see our own stuff, which is kind of weird, but here we are. So this is the first image, the AP caudal shot, and as you can see, there is severe mid-circumflex disease. That is in-stent restenosis. There is ostial and proximal circumflex disease, which is moderate, bordering on severe. I think it's more moderate, but a bit worse than what it was just last week. And I'll show you the next picture. And this is the spider view where you can see the LED lesion, you can see the circumflex, moderate, very calcific disease. I don't know if the calcium is showing through the transmission.
Yes, we can work out the calcium also.
Good. So, take it from me that the prox LED, the distal left main, and the ostial circumflex is heavily calcific. The mid circumflex has a stent, so that's not calcium, that's stent. Next, go to the next picture, please. No, back. So, and this is the AP cranial shot of the LED, and you can see that there is a tight lesion in the mid LED. There's moderate disease after that until we hit the mid distal LED, and there's calcium. I think the calcium is, you can appreciate that in the LED. And if you look at, focus your eyes on the distal left main, there it is quite narrow, and maybe if you, Rolando, can you freeze it to show the distal left main, the still image, there, right there. So you can see that the distal left main is quite significant. If you measure the caliber of the left main compared to the proximal left main, it's at least 60%, if not more. And then you see this gray shadow above and below that distal left main lesion, that is calcium. So this is where we are, and we'd love to know what your thoughts are and what would you do, and guide us as to what we should be doing.
Okay, now the case is open for discussion for the panelists first, and as we can see from here, it's a sizable circumflex, and there is a significant disease at the circosteum also. A lot of calcium, obviously from here what we can see is at least mild to moderate distal left main. So regarding, I would like to have comments from my panelists and my audience regarding the role of imaging and whether what will be the upfront strategy, single stent strategy or a double stent strategy. So over to our panelists. We'll start with Rosalie Mohammed. So what will be your...
my very personal feeling, I'd fix the spot on the LED and the circumflex and do the FR of the ostial LED and circ and see how that happens. And if it's there, then I treat it. Otherwise, if it's insignificant, I'd probably leave it. Just treat the mid LED and the circumflex and stop there. And if the FR fails me, he stays medical. That's my personal feeling. Now, Dr. Rosalie and Dr. Fahim and Sohail.
Fahim, usually I'm a bit careful about looking at left main in RAO views because of the overlapping of the circumflex, and you might think that is significant, but it's not. Obviously, I think the left main needs to be ascertained whether it's significant or not. I would tend to pick up an intravascular ultrasound to ensure if that lesion is significant and needs to be treated. If it's not significant, then obviously it's just the mid LED and right, mid LED and circ. I tend to use DCB for in-stent restenosis. The LED looks quite long. One may try to use DCB if the lesion is well prepared and has good results, otherwise it has to be stented. If the left main has to be stented, then we'll have to see again the ostial and proximal circ. If that lesion is significant, then it looks as if it is going to be a two-stent strategy for me.
Dr. Usman, what are your thoughts about the case?
Yeah, I would tend to agree with Rosalie. I think other than the mid-LED and the mid-circumflex lesions that are clearly very tight, we need to investigate the distal left main prox LED and prox circ more, and I would favor IVUS over a functional study just so that you can get plaque characteristic, you can size the vessel, and if you are to intervene on that distal left main, then you can plan your stent strategy as well. I think with that mid-circ severe ISR, I agree with DCB, but maybe cutting balloons to reduce the plaque or modify the plaque as much as possible might help as well.
Would you assess the left main with IVUS or FFR?
I would do IVUS.
I think the data strongly suggests for left main that IVUS would probably be a better choice. If it's less than 4.5, we're very clear. More than 6, then we're also very clear that we should not touch. Anything in between, if you're concerned, then that's where the role of FFR is.
Dr. Sale, what are your thoughts about the case?
Yeah, so very similar to what my colleagues have mentioned already. So the important thing here is that actually he's already had a stress test, and the stress test is concerning because the stress test has shown that he's got ventricular dilatation. So I suspect that the left mainstem is probably going to be significant. Often we underestimate left mainstem, so when we visually assess left mainstems, we know that we get this wrong in about 30% of patients. So I would opt to do IVUS of the left mainstem to look at the degree of stenosis, but also the calcium. So the patient certainly has risk factors for coronary calcification here. So they're diabetic and they have chronic kidney disease. And the other benefit of using the IVUS is, of course, you can use that also in the circumflex then to understand the mechanism of stent failure within the circumflex, because the patient's developed in-stent restenosis in the circumflex. So you could easily evaluate that as well. I suspect that the left mainstem here is probably going to be significant, and then you will need to decide whether you're going to go for a single or dual stent strategy.
Okay, Dr. Mansoor?
I think mid-LED and mid-left circ has to be done. Of course, if once we decide. Speak up. Yeah, I think assessment of left main is very, very important actually. But if you decide to do it, then of course you got to do circ along with it. So two-stent strategy will be appropriate for them. But you need to evaluate left main, because once you go into it, it's a major commitment. And how you do it, it's really based on different operators and different facilities available. But yes, I think if you do left main, then it's two-stent. And if you think you can wait for it or sit on it, then just mid-LED and mid-left side.
Dr. Rosalie, if you were to do a two-stent for the left main, would you stent all the way back to the ostium? Or?
I think the ostium is not very long, so if you want to use a pot, the shortest pot balloon is a 6 mm, but I tend to go until the ostium.
Okay, Fahim, the consensus from the experts sitting on the panel desks are that obviously everybody wants to do IVUS to evaluate exact the lesion severity, the amount of calcification, etc. Regarding the ISR of mid-circumflex, which you talked about, it's not a difficult option. If we want to proceed, we can go ahead with drug-coated balloon later on. But the real, decision-making fact will be distal left main and ostial circ. If it's significant, this ostial circ on IVUS or other pharmacological whatsoever testing you want to do, then obviously it has to be a two-stent strategy after IVUS with the circ and distal left main. It will be a two-stent strategy if it's a significant circ ostial disease. Over to you.
Great. I think those are fantastic thoughts. Rosalie has always got pragmatic suggestions, and I appreciate what Mansoor and Sohail and Usman are saying. We had a slightly different view on this, and I think a lot of that is driven by the extent of calcium we are seeing on the angiogram, which we thought was a lot. And so we basically decided that, our initial intent is or was and probably still is to be provisional for the circumflex. He is 75, he is HBR, and if we could get away with just dilating the circ and DCBing it under the current circumstances, which is, you keep in mind that this is surgical disease that we have sort of accepted we're going to do with PCI, it may be reasonable, albeit perhaps not perfect, to stick with a single sprint strategy and just go provisional. Now, having said that, the dilemma is or was in our minds is that we clearly see a lot of calcium at the circumflex, and rescuing and bailing out on a circumflex that's got a lot of calcium means that you're guaranteed that you're going to have a suboptimal stent result. So Jason and I looked at the images quite carefully, and we discussed it amongst ourselves, and we decided that we're going to go ahead and go upfront atherectomy first, then image, and then see what we're going to do, with the idea that we're going to do provisional with 2 stents in the LAD, one in the mid to proximal and the other one from the proximal to the left main, and try to treat this provisionally in this 75-year-old man who's high bleeding risk. So let's go forward let me just take you through what we did, and then we'll show you the IVUS, or rather Deborah will show you the IVUS. Go back, please, and then we need your suggestions, because that's where we are. So go back, please, back. So we decided to do orbital atherectomy, and let me just, maybe I'll ask Jason to comment, because he's really has the highest volume in our lab for orbital rather than rotablation, why we chose orbital. So while we're doing that, go back, please. I'm going to show you the wiring. We use the Viper Flex wire to just, that wiring picture, please. Next, please. Show the next picture. Stop, let it play. Let the last picture play, please. Back. All right, so while you're looking at the wire going, this is bare wiring the circumflex with the Viper Flex wire. So Jason, maybe you want to talk to the audience why we chose orbital in this particular case.
Well, in this particular case, you can see that the orbital is of a good size. At least it's 3.0 plus. And a good thing about the orbital system is it's one bird fits all size kind of vessel. So we don't need to swap it out compared to a rotablation, where you need to upsize the bird to a 2.0, and you do not need to change the guide in accordance to what the bird size is used. So so that's one strength of the orbital, why we decided to use this, and based on the anatomy, it's quite a nice straight run. Yeah. So in terms of complication risk, it's not high as well. So
the other advantage of orbital is that when you have larger vessels, which the left main is, even a 175 burr will not work very well, and you sometimes have to go to a 2 burr. But with orbital at high speed, you can address both smaller diameter vessels and larger vessels. So you can see we wired it. Next shot, please. Next. And this is now the, next, please. We first orbital the circumflex ostium. Next, please. And the patient actually had some ST changes when we did orbital to the circumflex. I think we did next 4 or 5 runs. I can't remember. But overall tolerated it fairly well. Next, please. Next, please. And you can see that that's looking a bit better after orbital. Next, please. Next. We'll just keep going. Next. Next, please. So, looking reasonable. Next, please. Next. We then pull this wire back and then put it in the LAD. So keep going forward. And it's not that easy but it is, you know, a much more usable, user-friendly wire than the current rota wire, but I'm told that the new rota wire is going to be excellent. Next, please. Just keep going next. And so then we did a few runs with the, we did runs at slow speed in the LAD and then at high speed in the left main. The slow speed is 80,000 RPM and the high speed is 120,000 RPM. Next, please. So just keep going and keep going, keep going. And what we're doing with orbital is we're listening to the pitch and try, and I wish we could have done that live, but just because of timing, we had to move forward. You're hearing a change in pitch just like with rotablation. The other difference with orbital is the motion. And maybe, Jason, you want to tell the audience how the motion is different with orbital versus rotablation?
Yep. So essentially, it's a very slow motion, forward and backwards. Try to do it a 1 second kind of move front, move back, very slow motion. So the good thing is it gives very good ablation anti-grid, and in some cases when there's tortuous vessels, you can do retrograde ablation as well. So that's another option and flexibility of the orbital system that we are seeing.
Next, please. And you can see the crown is moving slowly. It's not pecking. It's slow motion forward, slow motion back. Next, please. And what we'll do is now show you the picture we get. Next, please. After we've done the orbital ablation of the left main and LAD. And so, in some ways, it takes more time than rotablation because the motion has to be slow and you have to wait, 10-20 seconds between runs. And so what you're seeing is everything in real time. Next, please. So that's just we rewired, we dilated the LAD. Next, please. Next, please. And we got a bit of dissection when we dilated the distal lesion. And now we'll show you the picture where we are. Next, please. And so you can see over here that the distal left main definitely looks better in terms of luminal gain compared to what it was earlier. And I don't know if that's showing up through the transmission, but it definitely is. And this is the last picture we took. And you can see the distal left main. Maybe if Rolando can show you just freeze this picture in your mind and then look at the distal left main on the original picture. So same again, the cranial view is actually very good for looking at the distal left main because in the caudal view you get foreshortening.
Forward to the diagnostic.
Certainly it looks a lot bigger.
Diagnostic.
And just to sort of make that point, this is the picture now after orbital atherectomy, and we'll show you the picture before we did atherectomy. Just focus on the distal left main where it starts tapering down. And you can see that there is, same magnification, same everything. There is definitely luminal gain, and that's something that is pretty particular with orbital. Now, at this point, we decided to do an IVUS. We IVUS the circumflex and the LAD. So I'm going to ask Dr. Lee to show us the IVUS images. Deborah, over to you.
Yeah. Hi. Good afternoon, everyone. So
can you see the IVUS, guys? Yeah.
Yeah. So this is the IVUS pullback from the mid LAD. So as you can see, we found a good landing zone here. So I'm just going to show you the pullback. So here you can see the lumen is about 2.5 and the vessel is about 3.0 vessel. And it's approaching the focal lesion, which is of fibrous plaque, which we dilated with a 2.0 balloon earlier. So with this, you can soon see the septal coming in. Some calcium reverberation here. And then here the septal is coming in. And soon you're going to see the dia coming in from about 3 o'clock here. So you can see right here, 360 calcium here with some calcium reverberation. Then approaching to the osteo LED right here as the wire in the circ coming in to the left main. You can see calcium at 12 o'clock and also at 5 o'clock with some calcium nodule in both. And it's the left main, huge left main.
Okay. Let's look at the circ.
So this is the IVUS from the mid portion of the circ. So as you can see also, about 270 arc of calcium, near 360 of calcium.
It's quite tight at the ostium.
Yeah.
But
okay, you can see approaching this is the ostial circ right before the wire LED joins into the left main. So there's some disease in the ostial circ as well. Okay.
so in summary, there's, quite a bit of calcium, especially in the proximal vasculature. The LED, the distal left main has 2 big nodules of calcium. And remember, you're seeing this after ablation. We did not do a pre. We probably should have, but we just didn't. And the ostial circ has, significant calcium. There's been some luminal gain at the ostial circ. So the question now for us is, what do we do? Do we still do a 2-stent strategy, or do we do this provisionally? I'd love to know your thoughts. And while you discuss, we will sort of continue to work the 2515 NC.
Okay, while we discuss, we have got 15 minutes of time with you, and after that,
15 minutes.
Yeah, 15 minutes
Okay.
more left for you, because
Okay.
it will be a Jummah break here in Pakistan.
Oh, I see. Okay.
So, and
Okay,
after you 15 minutes, we'll switch to Beijing, China for the wrap up of the case, which they have almost done. And over to you,
Okay,
the
super.
panelists.
Fahim,
how would you proceed, Dr. Rosalie?
Sorry, just a question. Did you also OS the mid-circ, the instant restenosis?
No.
No, we're going to dilate that, and we will image that at the end. But yeah, I mean, that's something that definitely we will be doing. We just, in the interest of time, took a quick IVUS image of the proximal.
We have always been advised not to do OS in the stent because just in case.
No, sorry,
stent.
I missed your question. We did not go into the circ stent. Absolutely, you're absolutely right. We just ablated the proximal and mid circ. The stent is distal to that.
So the question which he has put to the panelist is, after all this orbital atherectomy to the circ and the LED and left main, single stent strategy or double stent strategy? That's what he has asked.
Yeah, tell us what you think.
12.
Dr. Rosalie, what's your comments?
I think looking at firstly at the LED, if there's a dissection there, then I'm a bit more, leaning towards stenting rather than DCB.
3020 NC.
I find that once you do OS, there are a number of patients that you can actually get away with just DCB alone. The result looks quite good. So I would agree with him that maybe you can try pre-dilatation first, prepare the vessel, and if the circ is fine, then not to stent the circ, but the left main stent to LED, I would stent it.
30NC.
Dr. Fahim, your thoughts?
Yes.
Yeah, so I think that's our thinking is that GOV20. Our thoughts were 2. One is that we need to we've atherectomized the calcium, but we haven't opened everything up. And as you can see, we're opening, and this 2.5 balloon is not fully expanding in portions down. So we may have to think about IVL or shockwave lithoplasty to open up that prox LED, which, if you remember on the IVUS, as Dr. Lee just pointed out, had a 360 ring of calcium, which maybe it had a fracture in one frame, but most of it looked pretty intact. Is that right, Deborah? Maybe you can show that again. So you can see up there, that's after ablation. So we're going to take a 3.0 NC and try to dilate proximally. And I think the thing to do is to re-image. And if we haven't cracked that calcium, then use something like IVL or a cutting balloon. I'd love to know what your thoughts are. There are clear cost differences between IVL and cutting balloons, so that's one issue. So what do you guys think?
Hi, Fahim, it's Usman here. I think looking at that degree of calcium, you could try cutting balloons, but you would probably get a pretty good result with IVL.
Yeah.
And I didn't see what the measurement of the osteal LED was, but if it's in the range where it's a significant stenosis, I would probably go with the 2-stent strategy right off the bat and not go provisional.
Are you talking about the ostium of the circumflex or the ostium of the LED?
The LED, the ostium of the circumflex clearly looks very severely diseased, but the LED, it's heavily calcified, but I'm not sure what it measured out to.
Yeah, short left main stem calcification and disease. The biggest cutting balloon right now is 3.0. But IVL does very well, and once you actually crack it, and it's really satisfying to actually see the fractures cracked, the calcium fractures, and you get good results following that.
How much IVL costs there in Singapore, Dr. Fahim? The IVS balloon?
A lot. It's in the 3.5 Sing dollar range.
Okay.
So give us a Wolverine 325. Yeah. Yeah. So I think I like the thoughts expressed. We are going to go with the Wolverine 325, which is a cutting balloon, and see if we can crack that calcium and then take another look. I think the way I look at it is as I think something that Rossley alluded to is that secure the LED, get the LED left main secured, and then we'll deal with the circ. If we will dilate it, we will DCB distally. We may not get to it while we're doing this live. And then, we will adopt a final strategy for the osteal circumflex depending on how things look. I'm just a bit wary that, even with all that calcium, in a gentleman who's 75, high bleeding risk, a less well expanded stent in the circ may not do so well. Just keep in mind that, he's got a circ stent that has already narrowed restenosed, and it just tells you what his biology is like. Of course, stents can narrow anywhere, done by anybody, but it just tells you what his biology is. So he really needs big stents with big lumens for them to stay open, I think. So just test there, show me. I think this was where it was, right? What do you think?
Yeah. So it's a 3.25 cutting?
Yeah. 3.25. We don't have a 3.5. I think they're out of... They're out of stock, or they're being there's a supply chain issue.
10,
12.
12.
So how high do you go with the cutting balloon? Rossley, Usman, Sohail, what do you guys do?
Well, 3.5 and above, they are, more than 3.0, they have actually taken out because there's some issues, technical issues with the balloons. So we don't have more than 3.0. But if you're going to use a 3.25 in that area, a cutting balloon, if you go slowly, I'm quite comfortable going up to 20 atmospheres. So that will give you at least half a size bigger.
1.6.
Yeah, I actually go up fairly high too at times, but they say don't do that, and there will always be the odd case that misbehaves.
Fahim, since when have you followed what company advice?
I tend to be quite compliant. No, you're right. So I think that there's a safety issue. But let's just go up here, 12, 14.
Yeah, the recommendations are that you should just go up to low pressure with the cutting balloon.
You should not have
what you don't want is to have your blade stuck in the calcium. And the purpose of the cutting balloon is just to make some lacerations within the calcium. And you can always follow that up with a non-compliant balloon. So, if you've only got a 325, you could go up to relatively low pressure and then chase that with a non-compliant balloon. There are certainly some positives on the IVUS here, because actually if you look at the IVUS, and I think this was mentioned as well, what we're seeing is that you've got some reverberation artifacts. And what that tends to mean is that, that there has been some positive effects of the atherectomy device within the vessel. Of course, we don't know what the vessel looked like on IVUS before atherectomy, so it's difficult to know whether that was present before or not. But certainly, if you have that sort of appearance, that's usually positive. It means that you're going to be able to crack that calcium.
And sometimes
so as you saw that with the 3.0 NC at 22 atmospheres, and with the 325 cutting, Wolverine. We got, at least on the face of it, looks fairly well expanded. The one thing I didn't do is to look at the balloon in 2 views. I think that's something that, just in the interest of time, I skipped that step. But it's always a good idea for fellows to know that a balloon can look really great in one view and look horrible in another. So you should take that extra minute and a few extra millisieverts of radiation to look at a balloon in the other view before you say that the balloon is fully expanded. But we'll find out. We knew that we were going to IVUS, so bring it closer. And so
you can always repeat the IVUS. I know we're a little bit short of time here, but one other option is once you've put the cutting balloon in, is that you repeat the IVUS study to see if there's been any impact.
That's exactly what we're doing, Sohail. So can you guys see the IVUS?
Yes, we can.
Yeah.
Okay. So this is from that midsection, where all the lesions and the dissections and other good stuff were.
Start recording?
Yeah.
Let's start recording. Full minute. Yeah.
You can see a little hematoma there.
Yep.
So you see some nice reverberations as you're coming back, which to me suggests that you've had some impact on the vessel there with the cutting balloon. And there's obviously disruption of the calcium as well with the cutting balloon.
Yeah. Okay, so Deborah, tell us what you think.
So the area where, stop here?
Yeah, we can stop here.
So the area where we saw the 360 calcium earlier, as you can see, there's calcium reverberations, and that's where the diet came in, and then followed by the 360 calcium here, right here. There's breaks in multiple points at 10 o'clock position, at 7 o'clock, at 6 o'clock positions, as well as 2 o'clock. So, yeah, and also the lumen is much bigger than the earlier. Yeah, so the 360 calcium is definitely
okay.
Yeah.
Disrupted. Yeah.
Okay, and the distal left main, we're happy with that?
Distal left main? Yeah.
Actually, we didn't get to that stage.
No,
we just left it there. But I think that's, Okay, so I think that what my thoughts are that, we'll put a stent in that mid-LAD and then go on and work on the circ, dilate the distal circ, DCB8, then re-IVUS the whole circ, and then make a decision as to whether we're going to put a stent in the ostial circ or not. I'm really a bit reluctant to do that in this gentleman, just for safety reasons, but certainly that's something we can think about. Deborah, can you tell us the length we need from the distal landing zone? Go to the original IVUS.
We'll go to the original
from the distal landing to perhaps that septal or just beyond the septal. 38 or?
Just at before the septal.
Yeah. So one thing about, the IVUS is it gives you a pretty good, so 38 kind of visually, okay. So 275, and do we have enough length to then cover the main? So we need to be a bit careful.
So let's measure.
So we want to put a Megatron in the left main.
Fahim, you just carry on with your work, and we'll be going to China for the wrap-up of the last case which they were doing, and we'll be coming back to you after 5 minutes, okay?
Okay,
and
sounds
then
good,
we'll
Thank
wrap
you.
up your case. Okay. Over to
sounds good.
China.
Okay.
Beijing, China.
So then we need
Professor
longer,
Wu's
right,
case.
Deborah? Because Megatron is 32. So give me a Megatron length of 32 from left main to wherever it ends. Okay, so then we need 48 then, right?
Please.
Surely and check. Yeah.
275?
Dr. Shen.
What is that lumen at the proximal tail end of this?
25.
So we are,
no, further down.
Professor Wu, we are with you, live back,
beginning
and
of the...
Dr. Charlotte Cheng is also with us,
Over
and
here,
we would
over
like to know the
How
wrap-up
many
of the
is
case.
I think 48 should do it, right?
永健，你听得见我说话吗？
Yeah.
啊，
Let's secure
那
that
你
and then
给我们
we'll
介绍一下
work
前
on
面
the
一段
circ.
你们这个工作取得的成绩。
48.
Already? That is, no, that's not ours.
It's China. Okay.
Go ahead，继续介绍。哎，很清楚，很清楚。
Okay, I got the wire.
Then nominal or below nominal?
I think 10, 12 should do it.
10, 12. 10 is below nominal.
Okay, 12. Store that, please. Test. Went very nicely, huh? Yeah, it's at that septum, right? Perfect. Huh? Let's take a picture. Yeah?
Yep. Okay.
Okay, let's go up here.
12.
Going up.
2.8.
Get the 2O compliant balloon ready. And get the 3O compliant NC ready. Give us a 3O first, huh? This is supposed to
open up nicely.
Yeah, just 30 seconds and then down.
Other wine for the anchoring. Next.
永健，你们能把造影继续播放造影的图像，一边讲一边放图像。
Okay, so can you find the picture?
Yeah, now we can see angiography.
Okay, next. No. Okay, yeah. So you see, so this the XY is so going to the branch. So that means the proximal, the right corner is in the true lumen, and the next. So let's give us so then we change the one. So this the XTR. So very slowly, and then we use the Calcified, the micro caster to support. But from here, so we find so this the one is not in the true lumen. Next. And so, but you see, so because this GR caster is not very strong, so this is a big problem. Because now the wine is up to the distal CTO lesion, and the micro the Calcified is count the move, and then so it's very slowly to manipulate the Calcified, the micro caster, and then we change another wine. So this is Gaia 3. Okay, next. So you see the Gaia 3 is going to the small bronze. So that means, so this is the true lumen. So then we change the direction. Next. So no, next. So this is round. This maybe the small the branch. So then we change the direction. So we're lucky. So the Y in true lumen. Why is still the problem? Because the guide caster is not very strong. So we try to train the seal, but it could not go forward. So and we try to take maybe 10 minutes. So then we finally decide to change the guiding next. Yeah, so we dilate the proximal right corner, but we can't cross. And finally, we change another guiding. So you see, this is the upper left 0.75. And so we use the 2-point balloon thin cross. So this is made in.
Let's just make sure we have good flow.
So next.
Picture for them or
okay.
Next. Okay, then we dilate.
Nice.
Okay, let's come epicaudal.
2.0.
This, I guess.
And we debut the left main.
Show you the iris fighting.
Okay, let's take the 2O balloon.
The iris.
Okay.
Open the CTO lesion. So we check with the iris, we find so the lesion is very diffused from the osteo to the distal. Okay, now it's okay. No. So okay, good. So this with check the iris from the distal.
Okay, thank you very much, Dr. Wu. It was wonderful having you with us on Pakistan Live 2022 forum. And the case has been wonderfully done. And congratulations to you for being the director now of this your hospital. And congratulations from all of us from Pakistan. Thank you very much for the great case. Thank you. Can we go back to Singapore? So now we'll be moving to Singapore for just 5 minutes for wrap up. For the announcements for the lunch break, there will be lunch break immediately after this session, and this will last till 2 o'clock. And at 2 o'clock in this very room, we'll be having a wonderful stroke session, which has been organized by Dr. Asim Javed of Rawalpindi Institute of Cardiology, with elite panel, accompanying him for just a wonderful session.
Yeah, I'm wondering. That's what I was looking at. So.
During the break, the lunch break, there'll be a session going on with Medtronic stall. Anybody interested, especially the postgraduate students, they can go there for the wonderful session there in the exhibit area at Medtronic stall. So we are going live back to Singapore for the wrap-up of the case which Fahim Jafary was doing. Over to Singapore.
Assalamu alaikum. Can you hear me?
Yeah, we can hear you, Fahim. Just wrap up
okay,
the case.
Okay, good. So we're still at it. I mean, let's just go back a picture. Let me just show you what we've done so far. So we actually should have lined these pictures up before, but we stented the LED, and I'll show you what that looks like right now. There, next. So this is next. Next. Yeah, so this is the LED after we put a 275/48 Synergy XD and we post-dilated it with a 3.0. So, you know, the mid-distal and prox LED is stented.
Where did the stent end approximately? You have
so the stent ends, proximally it ends just at the septal.
Just as the septal.
Okay, and so now we of course have to address the prox LED in the left main. So then we went to the circ, so move forward and we dilated the distal circ, the stent, initially with a 2.0 and then a 2.5. Our thoughts were to just DCB the whole area, and I'll show you what the picture looks like. And then, so not too bad. I mean, the stent, you know, despite going up to 22 atmospheres, you can see that the stent, you know, that little, you know, right opposite where that small OM is, you can see that the stent is still a bit narrow. Yeah. We haven't imaged it yet. So maybe calcific neoatherosclerosis, it could be any number of things. Our initial thoughts were to DCB it, and in fact I am going to DCB it right now. But then the next question is that, you know, if you play this image, the prox circ, you know, let's say where that recurrent atrial branch comes off, just beyond that is a little bit of probably a dissection. So that may sort of force our hand to put a stent over there. You know, I'm going to DCB this distally, and then we'll IVUS it to see. I mean, that's the plan, to IVUS it and see. I still would prefer not to have to stent that circumflex just because of the patient profile. But if we don't have a choice, we don't have a choice. So right now I'm taking an agent, what is this, 2.5 by? 30. 30 Taxol coated balloon for the distal.
So we are short of time. We'll like to know what will be your plans for distal left main. or the ostial LAD?
So the distal left main, we are going to stent from the LAD. So that's for sure. The real question only is that do we need to put a stent in that ostial circ or not? So we'll IVUS it and see, and then we'll know, because it looks like there might be a dissection over there, little picture. And if there is a dissection, then I think our hands kind of may be forced. So this distal diffuse disease, some of it is native atherosclerosis, some of it is in-stent restenosis. I'm not too keen to re-stent all of that. But the ostial and proximal circumflex, we may have to, if that is a real, dissection. We'll look at it on IVUS and see.
Okay,
again,
thank you. We are running short of time, and
thank you.
It was a wonderful case. What you have tried to show the audience, obviously, is the role of imaging for distal left main or the circumflex whatsoever. And regarding the calcium phenomenon also, and in this case, you have used orbital atherectomy instead of this rotational atherectomy and aided by the cutting balloon. And obviously, the results in the mid LAD are perfect, and you did well with this drug coating balloon. And obviously, whether you go with a single, I think your option is still with a single stent strategy for distal left main, and hopefully it will work. And thank you very much.
It's a great case, but in one of the cranial views, you could see there was a critical lesion in the circumflex, ostium and proximal. I wonder if that will affect your strategy.
Nine.
As I said, it might. I mean, we're going to look at it again on IVUS. On IVUS, the luminal area is not too bad, but after we ablated it, which we had to in case we have to do a bailout, there's a little bit of a dissection. Some of these you can still treat with a DCB. You'll be surprised how well DCB works. And we've used agent and other DCBs for cases like these with very good success. We have one of the world's experts in DCB in our lab, so we're a bit biased. But yeah, I mean, we'll be happy to update you on what we end up doing finally. But I'd just like to thank Pakistan Live for inviting us. I'd like to thank my colleagues, Jason Lowe, Deborah Lee, and at the back end, my colleagues, Dr. Ho, Dr. Cliff, Dr. Randall, Dr. Tet, all the staff who've stayed back to do this case at this hour. And but particularly thank you all for your input, and thank you for just having us be there in Islamabad with you virtually.
Thank you very much, Dr. Fahim, for being there in each Pakistan Live. You are a great friend of, you are from Pakistan and you are doing wonders there in Singapore. Thank you very much, and we can say goodbye from Pakistan. And we give a round of applause to you and your team.
And thank you for the panelists for contributing very well, Dr. Chen, Dr. Rosli, and all of you, Dr. Sahel.
Thank you very much, everybody, the panelists, the attendees, and now we, adjourn for the lunch break and the prayer break. The lunch is ready outside, and after the prayers, 2 o'clock here at the stroke session by Dr. Asim Javed and his team. And there'll be a Medtronic, quiz sort of a thing going on at the Medtronic exhibit booth during the lunchtime. So we request you all to be here right at 2 o'clock so that we are on time. Thank you very much. The prayers time is at 1:30. Just adjusted to the reception in the hotel. You can ask the reception desk for the route. Yeah.